Good morning. Today is the third day from our conference, and we will talk about pediatrics congenital anomaly. And as we know that congenital heart disease, it's the most common congenital baby can born with. It's more than about 21% of congenital anomalies is cardiac. It's more than CP, Down syndrome, or baby who born with other congenital anomalies. So first our speakers is Dr. Ismail Redha. Dr. Ismail Redha is graduated from Kuwait University, and he did his fellowship in Jackson Memorial Pediatrics Cardiology. Please join me and welcome Dr. Ismail Redha. He will talk about first lecture. He will talk anesthesia, disease in non-cardiac surgery, pre-operative assessment, and optimization.
Good morning, everybody. Assalamu alaikum. First of all, I'd like to thank Dr. Huda Al-Foderi for actually inviting me here, as well as of the entire organizing committee for such a lovely conference to be held here in Kuwait, and welcoming everybody from coming across the world overseas to be in Kuwait, enjoying the nice weather, which is chilly today. To start with, like I spoke to Dr. Huda, having a 20 minutes or a 15 minutes talk through such a topic per se, which needs sometimes to have books to be written about. So what I will do, I might be actually touching turfs on other people's ground, so I do apologize for that, but more or less I'll make it like a roller coaster ride to just get it over with in 15 minutes. That's why the colors are confusing, actually, the yellow, the blue, the red, and etc. So hopefully today, both with me and Dr. Maria, be able to discuss the principles underlying the management of children with congenital heart disease who present to their local hospitals for non-cardiac surgery in particular. And again, we emphasize for the local district hospital. Describe at a glance the physiology of normal and pathophysiology of some abnormal circulation. Suggest a classification of low to high risk children. Discuss some preoperative assessment, anesthetic management, and postoperative care of these children in the local hospital setting. As Dr. Hani was saying, congenital heart disease is the most common birth defect. Approximately in the literature, 1 in 125 live births are affected. In Kuwait per se, I think that goes up to 3 in 100 or 2 in 100. But again, there is no evidence based on that, based on studies. Due to advances in medical care, excuse me, majority of these patients, unlike 40 or 50 years ago, are surviving through adulthood. And thus, they are going through all life incidences, whatever they are going through, other, the general population, our patients with congenital heart disease as well, they are going through. So they are having emergency situation as well as elective surgeries. And in general, these patients have an increased risk of morbidity, perioperative cardiac arrest, and a higher 30-day mortality, for which we are going to discuss their cases in these few lectures. And the complexity of the cardiac defects and the variety of the non-cardiac surgery makes it impossible to generalize an approach to all of them, a one approach type of thing. For example, a 9-year-old child with a repaired ASD who requires an emergency appendectomy, simply appendectomy, presents minimal risk, yet a 12-year-old with a failing single ventricle circulation, having a Fontan, going for the same operation, has differently and totally risk factors involved in his case and his management. Some limitations to remember when it comes to pediatric age groups. The evidence for classifying children with congenital heart disease who require non-cardiac surgery as high, intermediate, and low risk is very limited. Few studies exist evaluating anesthetic techniques in children with heart disease for non-cardiac surgery. Studies for complication in a rapidly changing field such as cardiac surgery and their advances may reflect an outdated treatment strategies. So an ongoing, advances are going on in the pediatric cardiac surgeries, so therefore things are changing. The complications are changing. This review is intended for the District General Hospital again, and how they're going to manage these patients who are undergoing non-cardiac surgery. So to remember, the variety and complexity of our congenital heart disease makes a one-size-fits-all approach, like I said, will be impossible. I would just present few cases now just to remember, which we'll go through at the end of the lecture. A 6-month-old male with an unrepaired large VSD presenting for emergency surgery for a scrotal swelling. Second, a 6-year-old with a repaired tetralogy of Fallot presenting for dental extraction due to dental caries. Third, an 8-year-old with a Fontan circulation presenting for emergency surgery for reduction and fixation of a supracondylar fracture with neurovascular compromise, so he might lose his limb. So remember those 3 scenarios which we'll address at the end. Physiology of different types of circulation. And again, different books, different references, have different description of what I'm going to say. So there might be the nomenclatures not applicable to what we think for the congenital heart disease. So first we have the normal or serious circulation. The normal circulation, as it says, is separate systemic and pulmonary circulation working together in series. Applies to most types of repaired congenital heart disease. Some forms of unrepaired congenital heart disease also have a normal circulation, but with one or more defects where mixing of blood can occur, like an ASD or VSD, which are the most common. Left to right shunt result in increased pulmonary blood flow and potentially decreased systemic blood flow. Right to left shunt causes deoxygenated blood simply to flow into the systemic circulation, causing cyanosis and reduced pulmonary blood flow. Amount of shunting depends on the size of the defect and the pressure gradient, which is usually judged by the systemic and pulmonary vascular resistant. Changes in SVR and PVR as a result of anesthesia, including the administration of oxygen, simply have greatest effect on large unrestricted defects. Infants with a large unrestricted defect, such as a VSD, may exhibit balanced circulation physiology, as I'm going to describe in the following slide. So this is just a description of simply to remember simple holes like an ASD or a VSD. What happens when you are giving oxygen? What happens during ventilation, during anesthesia? And TOF, where you have a right-sided obstruction as well a defect which is mixing between both ventricles. So if we drop the SVR, systemic vascular resistance, or whatever agents we are using, we are going to have more of right to left shunt. And if we drop the pulmonary resistant, then we're having more left to right shunt. And accordingly, whatever happens to the patient. Balanced circulation or parallel circulation, the pulmonary and systemic circulation communicate with each other and function physiologically as being in parallel. The anatomical abnormalities causes the blood flow to the systemic and pulmonary circulation to vary depending on the relative resistance in each circuit. Thus, blood flow to the lungs and body is balanced between SVR and PVR, hence the term balanced. So depending on the resistance on each side, more flow will be to that lower side of resistance. Excessive pulmonary blood flow causes pulmonary edema and poor systemic perfusion, and insufficient pulmonary blood flow causes profound cyanosis. For example, for balanced circulation physiology, infants with a large unrepaired AVSD, AV canal, these infants have predominantly left to right shunt flow. High concentration of oxygen during anesthesia will increase pulmonary blood flow and reduce systemic perfusion. Conversely, large doses of induction agent may reduce systemic vascular resistance so much that shunt flow is reversed, causing desaturation and cyanosis. The excessive pulmonary blood flow also makes the child vulnerable to development of pulmonary hypertension by increasing PVR. Single ventricle circulation. The single ventricle pumps oxygenated blood around the body. So that single ventricle, whether being the left or the right ventricle, while blood flow passively to the lungs down a pressure gradient from the pulmonary artery to the left atrium, the wedge, what we know as the wedge pressure. So initially these patients, a lot of them undergo a BT shunt, but not necessarily all of them, but all undergo a Glenn anastomosis, which is between the superior vena cava and the ipsilateral pulmonary artery, usually the right, at 3 to 5 months of age. And usually these patients' saturation ranges between 75 and 85%. So knowing that is important. And their final stage of repair is usually ending up by the TCPC or the Fontan circulation, where IVC is connected to the ipsilateral pulmonary artery, which is usually the right pulmonary artery. And by that, they will have a normal full saturation, unless there is a problem and there is a fenestration. The pressure gradient from the pulmonary artery to the left atrium is now the sole determinant of pulmonary blood flow. Therefore, increases in pulmonary vascular resistance and intrathoracic pressure can compromise pulmonary blood flow. And this is important for the anesthetist to know. So they are on a passive circulation phenomena. Spontaneous breathing causes negative intrathoracic pressure and augments pulmonary blood flow. So always is ideal. Positive pressure ventilation may allow greater control of oxygenation and minute ventilation, thus avoiding hypoxia and hypercarbia. Positive and expiratory pressure should be optimized as well, and peak inspiratory pressure and expiratory times minimized to facilitate pulmonary blood flow. And in general, avoid high PEEPs when patients are on ventilator and patients with single ventricle physiology who have Glenn or Fontan. Because high PEEP, as everybody knows, will increase your pulmonary vascular resistance and therefore compromise that flow, that passive flow. This is an important, actually, table for risk classification of children with heart disease undergoing non-cardiac surgery. I'm showing it now, and then it's important to know that it is based on different itineraries for risk classification for patients. So we have the low risk, intermediate, and high. And all it depends on the physiological status of the patient, whether he has some complication, including cardiac failure and pulmonary hypertension, complexity of the lesion, that's the cardiac lesion, the type of surgery, major or minor surgery, and whether it's emergent or elective surgery, age of the patient, preoperative hospital stay, as well as the American Society of Anesthesia physical status of the patient, which ranges from 1 being having the organ, no organ being affected, till 6, which is basically a brain dead patient. So we'll not be dealing till 6, I think. We'll go up to 5. So first, in that risk classification, the physiological status risks. Cardiac failure. Cardiac failure can be due to a volume overloaded heart or a pressure overloaded heart, or in some situation, both. Volume overload may result from residual shunts or incompetent valves, as is common after TOF repair, for example, or AV canal repair where you have AV valve regurgitation being significant, and pressure overload from residual outflow tract obstruction. Children with severe cardiac failure must be identified because they are at very high risk. And a recent study had shown that 10% of suffer cardiac arrest and 6% required perioperative inotropic support. These children should be transferred to a specialist center even for minor procedures, these high-risk patients. In the emergency situation, children may need retrieval by a specialist transport team. In the rare event of transfer being impossible, advice should be sought from a tertiary center, pediatric cardiologist, and pediatric cardiac anesthetist services. Children with milder degree of cardiac failure pose less risk. In the local hospital setting, either gaseous IV induction is possible, but induction times will be prolonged, so patience is needed to prevent excessive drug administration. Avoid prolonged use of sevoflurane, I'm now touching on other people's turf, like I said. Propofol may cause a profound decrease in cardiac output and is best avoided as an infusion drug, though it's one of my favorite. Ketamine is the IV agent of choice. Venous access, as simple as venous access,
5 minutes. 5 minutes.
May be difficult, so having a second experienced anesthetist is often helpful. We will be dealing with patients like this. It's important to know the determinant of cardiac output. Keep that in mind. As well, what are the factors which worsens your heart failure? One important thing that anesthetists, at many occasions, they ask us when patients are on heart failure medication whether to stop or not. There is a consensus that actually in pediatrics, unlike in adults, you don't need to stop any of the medication. In particular, the anesthetists are worried about the ACE inhibitors, so you continue. Pulmonary hypertension. I'm sure that everybody knows pulmonary hypertension. If a child receiving treatment for pulmonary hypertension, they should be transferred to a specialist center where full pediatric intensive care facilities are available. Arrhythmias. Most of our patients who have some sort of ventriculotomy, they have right bundle branch block, but that doesn't necessitate that they have complete heart block. So right bundle branch block is nothing to worry about. But having ventricular ectopies is an ominous sign. So when you have an ECG with ventricular ectopies on a patient, that is considered as a high risk. Children with ventricular ectopy on ECG or a single ventricle circulation should be referred for surgery in a specialized center. So your ectopies, and the second one is actually a complete heart block. Cyanosis, I will go. What is important regarding cyanosis is chronic cyanosis, which affects major organ systems. The main problem relating to anesthesia and surgery are polycythemia and coagulopathy, increasing risk of hyperviscosity causing cerebral vein and sinus thrombosis. Dehydration, fever, and iron deficiency anemia increases the risk. Preoperative IV fluid therapy may be used to minimize this risk. Very importantly, aspirin should not be stopped. This is a common, usually, again, in most of cases. Complexity of heart disease, single ventricles, balanced circulation, cardiomyopathy, severe left ventricular outflow tract obstruction in particular. Types of surgery, of course, between simple and major surgeries. We go back to the same slide that I introduced earlier, which actually stratifies patients according to the risk classification.
2 minutes.
I think I started a bit later. So, key features and preoperative assessment. This slide is important to remember. Knowledge of the underlying lesion and type of circulation. Are changes in SVR, PVR likely to be of significant importance? Evidence of recent upper or lower respiratory tract infection is very important. Venous access, like we said. Routine drug therapy. So again, there is no need usually to stop anti-failure medication in particular. Aspirin should be continued in most of cases. Sedation as a premedication commonly is used to avoid distress, minimize oxygen consumption, and may also reduce the amount of induction agent, so minimizing reduction in SVR. Endocarditis prophylaxis to follow the national guideline. As for the SBE prophylaxis, all these councils on the slide, actually, they gathered together in 2007 and they revised the SBE prophylaxis recommendation. They concluded only an extremely small number of cases of infective endocarditis might be prevented by antibiotic prophylaxis for dental procedures, even if such prophylactic therapy were 100% effective. So only extremely small number. But still, we have to do it on the high-risk patients. Infective endocarditis prophylaxis for dental procedures is reasonable only for patients with underlying cardiac condition associated with the highest risk. Among those, prosthetic cardiac valve or prosthetic material used for cardiac valve repair, previous infective endocarditis, some congenital heart disease, including palliative shunts and conduits, complete repair congenital heart disease with prosthetic material or devices, only during the first 6 months after the procedure, or some other residual lesions which are adjacent to such synthetic materials. Cardiac transplantation recipients who develop cardiac valvulopathy. The last conclusion, administration of antibiotics solely to prevent endocarditis is not recommended for patients who undergo a genitourinary or gastrointestinal tract procedure, which is commonly endoscopies. This is antibiotic regimen. Surgery in anticoagulated patients, a question which usually arises, when it is safe to operate when long-term anticoagulation is involved. The answer, there are no precise consensus, but recommendations are there. Generally, dental extraction, minor biopsies, ophthalmic procedure, and diagnostic endoscopies are safe without altering anticoagulation regimen. Elective invasive surgeries with INR around, best to be around 1.5, and therefore stopping warfarin if the patient is on it at least 4 to longer days, depending on the INR status prior to surgery. Emergent surgeries, we can reverse the INR to normality with FFP, vitamin K, and prothrombin complex concentrate. For aspirin, American versus Europeans, I personally don't stop it like we said. Plavix, and some of the patients in pediatric use it in adults more, but we have some kids on it. We stop a week prior to surgery. And we can always achieve active anticoagulation or prophylactic anticoagulation with low molecular heparin or unfractionated heparin.
Finish this last.
So it's important to go actually to the, these things I think Dr. Maria are going to discuss, propofol, ketamine, and let's go through our examples that I started at the beginning.
Time is finished.
Okay, shall I? So these are just the last 3 slides. So the 6-month-old with an unrepaired large VSD presenting for emergency surgery for a aortic swelling. Physiology, compensated on examination, moderate cardiac failure, on diuretics, but feeding well and gaining weight. Lesion is simple, awaiting VSD repair next month. Risk category, intermediate, physiologically well compensated, simple lesion, minor surgery, but less than 2 years old. And it's an emergency surgery. Management depends on a local anesthetist and surgical expertise. If local hospital routinely performs surgery on children under 2 years, then safe to undertake locally. Otherwise, consider discussion with and transfer to a specialist center. Anesthesia consideration, slow gas or IV induction. Be aware of possibility of poor cardiac reserve. Avoid high inspired oxygen concentration in order to minimize left to right shunt and maximize systemic perfusion. May require higher ventilatory pressures than expected because of presence of pulmonary edema. Avoid air bubbles in venous lines because of the risk of paradoxical embolus. Endocarditis prophylaxis is unnecessary. The 6-year-old with a repaired tetralogy of Fallot for dental extraction due to dental caries. Physiology is compensated on examination, good exercise tolerance, no sign of right failure. ECG shows our right bundle branch block and no ventricular ectopies. Lesion is simple. Risk category is low. Management, perform procedure in local hospital. If ventricular ectopy is present on ECG, considered to be high risk and seek cardiology advice. May need to postpone surgery or transfer to a specialist center as high risk of life-threatening arrhythmia. Anesthesia consideration, gas or IV induction, no need to have endocarditis prophylaxis. The 8-year-old with a Fontan circulation presenting for emergency surgery for reduction and fixation of a supracondylar fracture with neurovascular compromise. So this is a major thing and carries a high risk. Just for the anesthesia considerations, gas or IV induction, consider spontaneous ventilation as this aids in pulmonary blood flow, but must avoid hypoxia, hypercarbia, and atelectasis, which increases our PVR and compromises pulmonary blood flow. Full stomach may require rapid sequence intubation and positive pressure ventilation. If using positive pressure ventilation, avoid high pressure, high PEEP, and long expiratory times. Slight head-up position simply can aid venous return and pulmonary blood flow, and so does the raising of the legs. Endocarditis prophylaxis is not used. So in general, I would say, for the anesthetist, it's good to know your patient, know your medications, what they do to this particular group of patients, do what you can do best and what you know best, and never hesitate to ask for an advice. Thank you, and sorry for the rapid sequence of